Post Herpetic Neuralgia, Shingles complication. Let's take the first note. Self-representation on shingles will be out very soon. Here, someone would have developed chickenpox in the past with varicella zoster virus, got treated with antiviral agents, analgesic steroids, and the like. Then the virus will undergo latency. The virus will go and hide in the neurons of the cranial or dorsal root ganglia, and that will be as long as we live, lifelong. But certain things will happen. You increase in age, or immunity is depressed, and there'll be reactivation. Shingles with herpes zoster virus will have features that will include rash, pain, fever, headache, malaise, and so on. The pain will be from neuronal damage. Then, after the treatment of shingles, we'll still be battling with complications. And the most common complication is post-herpetic neuralgia, which is a profound pain lasting at least 90 days after the onset of rash. Post-herpetic neuralgia will occur in 12 to 20% of everyone who will develop shingles. The older we become with shingles, the higher the probability of post-herpetic neuralgia. In post-herpetic neuralgia, which is the most common complication of shingles, pain here will remain after the rash would have disappeared, and that pain will last for the minimum period of 3 months. Hence, the name post-herpetic neuralgia, after the herpes zoster virus appearance and the rash has disappeared, then the pain will persist. The incidence of this condition will increase as we get older. Unfortunately, there is no cure, but it could be ameliorated. Let's go through the clinical features again. Shingles was in this man or woman before, with rash, pain, fever, malaise, and so on. But rash gone now. The pain of post-herpetic neuralgia will be localized to the previous rash region. The characteristics will include burning, sharp, jabbing, aching, electric shock-like. There might be allodynia, meaning the individual will be sensitive to pain from a stimulus that ought not to cause pain at all, like feather or just a piece of cloth. There may be aparalgesia, in which case there is a painful stimulus, but the response to the stimulus will be beyond expectation, meaning exaggerated response. The duration of this condition is long. It could take months or even years. There will be associated photophobia. They don't want to see light. There can be numbness or itching. Some will find it difficult to sleep, insomnia, depression, anhedonia, meaning they are no longer interested in what usually gives them pleasure, like vacationing, camping, and so on. Even the diet could change, meaning they will eat less or no interest in eating. How can we make diagnosis here? I will not waste your time. There will be full info on shingles. There, I will go into details as per solving taking samples from vesicles, polymerase chain reaction, enzyme-linked immunosorbent assay, serology, and so on. But for post-herpetic neuralgia, pretty easy. The history of chickenpox is there, that this person had chickenpox in the past, and after some years, shingles has emerged, and we could see the spread along a particular dermatome or along a particular root of the nerve. We'll do the physical examination to pinpoint where the pain is. Remember, no more rash. What are the possible risk factors here? Age. Age. That is the most important risk factor when it comes to shingles and post-herpetic neuralgia. The older we are, the more the likelihood. No past shingles vaccination could make it worse or let it occur faster. I'm not saying that with shingles vaccination you cannot have it. No, I'm not saying that. But it can delay it and reduce the severity. In fact, that is accountable for the reason why many people who had received vaccination in the past will not develop shingles on time. The site where the shingles occur is another factor. For example, it is worse to have post-herpetic neuralgia if it is located in head and neck region. The severity of shingles will also dictate how horrible the post-herpetic neuralgia might be. Like moderate to severe shingles will likely give us more trouble than mild shingles. The time interval between the onset of rash in shingles and the treatment will also be another factor. For example, if we'll start treating shingles within the first 72 hours of the onset of the visible rash or definitive diagnosis, the probability and severity of having post-herpetic neuralgia will decrease. Still on risk factors, the main issue besides the age is immunity. Anything that brings down the immunity will give us the chance of having shingles. For example, autoimmune conditions. And the individual is now having shingles. Remember why treating autoimmune conditions will give immune suppressants. Then we are suppressing immunity. Someone with HIV or tuberculosis will be battling with cellular immunity depreciation, then giving rise to reactivation of Zika virus, giving us shingles. Someone is having diabetes mellitus. Remember, diabetes mellitus on its own can suppress immunity. On top of that, on its own, diabetes mellitus can give neuropathy. Now, someone with low immunity due to diabetes mellitus having shingles is now having another neuropathy known as post-herpetic neuralgia. Cancer and the cancer treatment with chemotherapy or bone marrow transplantation will all lead to decreased immunity and increase the chances of shingles with the associated complication. Now, post-herpetic neuralgia being the most common one. Still on risk factors, I'm back. Immunity again. Why that? Age and immunity will determine whether we have shingles, and the severity of the same that will determine post-herpetic neuralgia and the trouble afterwards. Now, someone is on steroid or on disease-modifying anti-rheumatic drugs, or someone had undergone transplantation and now on immune suppressants to prevent rejection, All these, including stress in life or chronic diseases like chronic kidney disease and so on, will decrease the immunity and increase the chance of coming down with shingles and post-herpetic neuralgia. Still, on risk factors is more in older females than older males, and more in whites than others. Prevention. Prevention, they say, is cheaper than cure. Is there no way out? There's a way out. How? Okay, vaccination. Shingles vaccine is very helpful to prevent shingles, not to prevent chickenpox. So, in anyone 50 and older, it is better to have shingles. If you are 18, but you are immunocompromised, with the probability of running into shingles and later on having post-herpetic neuralgia, be vaccinated as well. Even if you have been exposed to chickenpox in the past, don't think you are immune for life. No, have shingles. It's just 2 doses that will be at 2 to 6 months apart. But contact your physician or pharmacist before vaccination. Now, treatment. Unfortunately, there's no cure, but the condition could be ameliorated, like I stated earlier. We will be using multiple medications here. We will start with lidocaine patch or capsaicin patch. Then, if we are not winning, we'll continue by adding anticonvulsants like gabapentin, that is Neurontin, or Lyrica. Antidepressant like tricyclic antidepressant amitriptyline. In elderly, let's go for nortriptyline, venlafaxine, duloxetine, or whatever is approved for the use of these in your jurisdiction. If we are not winning, we'll move a step further. I don't want to get into opioids, but we cannot allow that man or woman to be suffering. We'll go for oxycodone or tramadol. If we are still not winning, we can go for steroid. Could see this. We're going to inject this through intrathecal route. Finally, there is room for referral to pain experts, neurologists, psychiatrists, psychologists as you deem fit. With that, I come to the end of this short presentation on post-herpetic neuralgia. It is the most common complication of shingles. Thanks for listening. Please share this with all your friends on your platform. I appreciate it.